I'm Dr. Bill Sischek. I am the Vice President of Medical Affairs and Medical Education for St. Joseph's Healthcare London. Thank you for joining us this evening for our DocTalk lecture series presented by CIBC, our sponsor. Dr. Harold Kim, who is here with us tonight, is one of those extraordinary physicians. He will share with us how his team is making a difference in the area of food allergies. He will explain how certain food allergies can gradually be reduced or eliminated through the process of immunotherapy. We're very fortunate to have him with us this evening. Please join me in welcoming Dr. Harold Kim.
Thank you. Thanks, Bill. All right. So thanks for coming out, and thanks for the sponsors and the foundation for organizing things, especially Matthew Overall, who I think is back there. He's going to wave his hand whenever my mic goes down. So the talk will be, I think, about 45 minutes, and then at the end we'll have some time for questions. Usually through these medical talks, we present cases. We have a slide with a case presentation. Today we're lucky enough to have Lauren Cohen, who's going to actually present her own case and talk about her experience going through immunotherapy. So it's going to be nice to have a real life experience. So we'll have Lauren speak about halfway through the talk before we get into the immunotherapy section. So this slide is an overview slide about food allergy, and the main part of the slide I wanted to focus on was here. And I put this word at the bottom just to remind myself to mention that we think over the last few generations in Canada, the reason we've seen such an explosion in allergy is because we're all too clean. And there's lots of variables like us living in urbanized centers as opposed to growing up on farms, us having smaller families. Larger families probably protect us from becoming allergic. All kinds of variables, antibiotics, those sorts of things have contributed to the hygiene and why we've seen a takeoff in allergy. Food allergies specifically, we believe we've seen an increase because we made the wrong recommendations about 15 or 20 years ago, or maybe 20 to 25 years ago, where we suggested to everybody, parents specifically, to avoid all the high-risk foods and to not eat the foods until your child was 4 or 5. And in retrospect, we actually were wrong. And now there's a couple of very big, well-done studies showing that we should be introducing highly allergenic foods at 4 months of age. So I'll show you a slide about that. So I think these two things, hygiene and us screwing up, has contributed to the allergy epidemic, where we now have about 500,000 kids with food allergy in Canada alone, and about 2.5 million Canadians. So it's a big problem. And this is an important point, is that at least half of households are affected, either directly or indirectly with food allergies. So it's a very, very big issue in Canada. And this slide is to illustrate the point that there's a shortage of us as allergists taking care of our patients. If you look at Ontario, there's 84 allergists, which translates to about 0.6 allergists per 100,000 population. So even in Ontario, we're underserviced. Our wait times in London are over a year for all of us now, so we really do need help. There's some provinces, specifically PEI, that does not have an allergist yet. So we have an allergist working with us now, Hannah Roberts, who's from PEI, and hopefully she'll be setting up there to make it 100% penetration, at least in terms of allergists being in every province across Canada. In the north, there are no allergists. So I thought I'd break it down, the talk into 3 main sections. So we'll talk briefly about how we diagnose food allergy now, because that's changed a lot over the last 5 or 10 years. We've started to do more oral food challenges where we actually challenge kids and adults who we think may or may not have allergy, and we make the decision based on whether they can eat it, which of course makes sense. Of course, the problem with oral food challenges is that there is some risk of reactions. There have been 2 highly publicized deaths from food oral challenges, one in the southern US and one in Europe. So this has to be done very cautiously. In our clinic here, we probably do 5 to 10 per day, I think, would be a reasonable estimate. So we do a lot of these challenges. And then I'm going to talk briefly about epinephrine autoinjectors. You probably heard last summer there was an EpiPen shortage. So we actually had to ration EpiPens. We were lucky enough to get a backup from the US, at least for 1 year, and we're cautiously optimistic that we'll get a few other companies bringing products to Canada. But this is a big issue as well, and we'll talk about some of our research with epinephrine autoinjectors and why we have to maybe modify what we do with these products. We'll talk about that. And then, of course, at the end, we'll talk about especially peanut immunotherapy, because that's where most of the science is. And we'll present some of the research to you and just some of the background of what we do here and how we do it. And of course, we'll have Lauren speak before we get into the nuts and bolts, no pun intended, about peanut immunotherapy. So the federal government actually identified these 10 allergens as the primary food allergens in Canada about 5 or 6 years ago. And they actually produced, with the assistance from the Canadian Allergy Society, as well as the main patient group, Food Allergy Canada, they produced really nice handouts for these allergens that are available online for everybody. If you do a search, you can find them. And we actually hand out information from the government, handouts for patients. They're actually quite good. So all of these foods, of course, I think you would identify as common allergens. The big ones are milk and egg early in kids, and then peanut, of course, is a huge one. Tree nut allergy can play a role, especially in adults, but we're seeing it more in kids as well. But all of these foods can potentially be serious and life-threatening. We're going to focus especially on peanut. To give you some background in terms of what an anaphylactic reaction or a severe allergic reaction is, it's a reaction that shouldn't occur. These mostly proteins from these foods are benign and shouldn't cause us any harm. But many of us, about 7% of us in Canada, have developed an abnormal immune response against proteins in the food. And so when we eat the food, our body overreacts and we end up having severe symptoms sometimes and occasionally deadly. So these are the organ systems that can be affected. And the skin, about 80 to 90% of patients, when they have anaphylaxis, there will be some skin symptoms. The two systems that can be affected that can lead to death are the cardiovascular system and the respiratory system. So the most severe reactions, we will give a challenge. In our clinics, actually, allergy shots are the most common cause of anaphylaxis. But if we have a patient have low blood pressure, then they're obviously potentially at risk of dying. So cardiovascular, and then of course if there's severe airway inflammation or throat swelling, then they can have death from respiratory symptoms. So these are the symptoms that can occur and the things that we're trying to prevent, obviously. Another important point is that anaphylactic reactions happen very quickly. So typically a child will eat the food and within minutes they'll have symptoms. Almost always within half an hour. Rarely it can be a bit more delayed than that, but it's usually very fast. And then another point that's made, and we'll talk about this a bit more, is that we should have epinephrine autoinjectors for immediate treatment. I just had a patient today actually who called me while I was working in the clinic who's on peanut immunotherapy. And mom called me while she was driving for, I think, an endocrinology appointment at the south end of town. But the kid was actually reacting to a peanut dose that she had about an hour before. So I, asked mom to pull over, give her daughter the EpiPen, and then they pulled into University Hospital Emerged. And the EpiPen worked within minutes. Her throat symptoms and breathing symptoms improved right away. So this is really important, and we'll talk about that a little bit more. So how we diagnose food allergy is relatively simple, yet complicated. The simple aspects are that, as I've mentioned, someone will eat a food and they'll have those immediate symptoms. And then we will see those patients when they're referred, usually from their family doctors. and we'll perform skin testing, which is fairly simple to do, and I'll show you an image of skin testing in a second. We now utilize blood testing more, so unfortunately it's not covered in Ontario to get this done, but we will measure the specific allergy antibodies against the food in the patient's blood. And then, as I've mentioned, the gold standard now for diagnosing food allergy, if we're not sure, is we actually have the patient eat the food in a supervised fashion, very cautiously, to see if they can tolerate a small serving amount of that food. So again, we do that quite often. So skin testing is rapid. We get the results in 15 minutes. It's very cheap. OHIP pays us 80 cents for a skin test, not a lot. And it's very accurate, actually. So if the skin test is negative, especially if we use a real food for skin testing, where we actually put the real food on the skin and prick the skin, the skin test is about 95% accurate if it's negative. So it's very, very good at ruling out food allergy. So typically what we do with skin testing is we have a drop of the food on the skin. Our newer skin testing lancets are actually plastic, and they're coated with the liquid of the food on the bottom. And then we just barely pick the skin. And I think you can see this here. Maybe down here it's a little bit more obvious. In 15 minutes, we look at the skin, and if there's a swelling, it's quite obvious, of more than 3 millimeters, then we've made confirmed the diagnosis of a food allergy. If the test is like this and it's really negative, then the patient is not allergic. So we've probably ruled it out. And often if this food's negative and the patient has said that they think they're allergic to it, then we will give them the oral challenge. So I'm just going to talk briefly about a study that we did, and this actually is a big shift that we've had in food allergy about maybe 9 years ago. Historically, what we've recommended for egg and milk allergic kids, egg allergy typically is the first allergy that starts in babies, and milk often around the same time, usually between 6 and 8 months of age. What we used to tell patients is that, or parents, is that their kids should avoid all milk and egg products, usually until they're about 5, and then we'd reassess them and we'd try giving them a challenge to the milk or egg. But we realized that about 70% of kids with milk or egg allergy can actually tolerate the food when it's baked in a wheat-based product. So a muffin or a waffle, a muffin and waffle, that was the original study. So I thought, well, why don't we try to make it even safer? And because you don't even want our 30% of kids anaphylaxing to the food, why don't we actually take the muffin after the parents have baked it with milk or egg in it, skin test the kid with the real muffin on the skin, and see if that adds more accuracy to our diagnostic approach before we give the oral challenge. So we did that. So we had 130 kids with milk or egg allergy. They were positive to the regular skin testing. But then what we did was we took all of these kids and actually skin tested them with a slurry that we made with the muffin that they baked, the parents baked. And so 58 of these kids had negative skin tests to baked milk or egg. And then we gave all of these kids an oral challenge to the muffin, and they all passed except 3. One kid actually did have a significant reaction. 2 kids had mild reactions, but you can see the accuracy now is way more than 30%. So now when we do this, almost always we can challenge these kids with the muffin, and you can see the quality of life improvement because now all of these kids can eat baked wheat-based products with egg or milk in it, and so birthday cakes and all of that stuff they can eat now. This just shows our study graphically that in the 58 kids that had negative testing, 1 kid had a severe reaction, fairly severe reaction, and the other 2 mild. But you can see the vast majority, 95% of the kids were able to pass the challenge without any worries. So I recommend this for most of our allergy colleagues, even in their private practices outside of hospitals, that if the skin testing is negative to the muffin, they can just go ahead and have the kid eat it cautiously in the office. So the next section I want to talk about was the epinephrine autoinjector. And the EpiPen is the main product that we have in Canada, and in some ways the only product that we have in Canada with this treatment. So we make a diagnosis of food allergy, and then we have a plan to try to prevent reactions from happening. So What we've recommended over the last several decades with food allergy, before we've started oral immunotherapy, is it was pretty simple. You avoided it, and you kept EpiPens available. And typically we recommended that all patients carry 2 EpiPens in case one wasn't enough, or if one misfired, we wanted them to have 2 EpiPens. So this was the standard. One thing I'll point out that a lot of people believe is the treatment for food allergy is antihistamines. And antihistamines might help with some of the mild skin symptoms, but they really, really need epinephrine to treat a severe reaction. So the EpiPen is what is typically recommended. And so if a patient has anything more than mild symptoms, then we recommend that a patient use their EpiPen immediately. And so they should give it in the thigh, and I'll show you in a second how to use it, because there's some modifications that I recommend for, especially for young children that have the requirement for epinephrine, because I'll show you one of our studies where we actually showed that between 30 and 40% of small kids might actually inject the epinephrine into the bone. And we don't want that, because if you get the injection into the bone marrow, then it's like giving the drug intravenously, and it could be potentially harmful and maybe deadly for patients. So I'll talk about that in a second. But if they have lightheadedness or breathing symptoms, they should use it right away. Or even if they have just skin symptoms that are progressing rapidly, they should use the epinephrine right away. And I'm going to bring this closer just so I remember to show you guys how I recommend using it. So the epinephrine is available in 2 doses, the EpiPen Jr, which is 0.15 milligrams, and the full EpiPen, which is 0.3 milligrams. And it is recommended to use in emergency treatment of anaphylaxis, not just for food allergy, but any anaphylactic reaction, such as insect stings. That's another common thing that we see. And we want the epinephrine to be delivered into the muscle, because we know that if you inject the epinephrine into the fat, then you won't get adequate epinephrine levels. And if you inject it into the bone, then it might not fire at all, because it might get plugged by the bone. Or if it goes into the bone marrow, as I mentioned, it could get injected almost like it's intravenous, and it could be bad. So what we want to do is inject it intramuscularly in the thigh. There's also studies done actually from Winnipeg showing that if you inject it intramuscularly in the deltoid, where many people would think that's where you give an IM injection, if you inject it here, it's the same as injected in the fat. You don't get high levels. So we really, really want to inject it in the thigh. And there's 2 well-publicized cases where in England, 2 young girls died. And in both cases, the coroner pointed out very strongly and clearly that one of the reasons that these 2 kids died was because the epinephrine did not go in the muscle. And so this was the first famous case. This was a medical student. Her name was Poppy. I think she was 19 years old, was allergic to peanut, and she had peanut by mistake. I think it was at the medical school. And she gave herself the EpiPen, and then there was a rebound reaction, gave a second dose of the EpiPen, and then there was a feeling that she was going to be okay. So she was waiting for the bus to go home, and she collapsed and died at the school, I think at the bus stop. So when they did the coroner's case and the autopsy on her, they could obviously see where the EpiPens were injected, and the coroner identified that the EpiPen needle was not long enough to get into the muscle, and perhaps one of the reasons she died was because the drug wasn't delivered into the muscle. So it was very clear, and I think, you know, really in terms of whether that girl got the EpiPen in the muscle was black and white. She did not. So that was one reason that they felt that she may have died. This was right around, actually, we started doing our studies just before she died, and I'll show you the results in a second. But just before she died, we started ultrasounding patients' legs where we were concerned maybe the epinephrine would not get into the muscle, and I'll show you our findings in a second. The other famous death happened about, I think, 2 years ago, maybe 3 years ago. A young girl named Natasha. She ate at a pret-a-manger. I think she was at an airport in England, and she was flying to France. And she had a food that had sesame in it, and she had an anaphylactic reaction on the plane. Her father appropriately gave her 2 doses of the EpiPen on the plane, but she died. And in her coroner's case, one of the findings was the same, was that they felt that the epinephrine from the EpiPens may not have gotten into the muscle because she had more subcutaneous tissue or fat than the length of the EpiPen needle. So, this case reminded us that maybe the EpiPen's not designed properly for all of us. So we've done a number of studies in this area, but the two of the original ones, one was expected, the findings were expected. This was the first one in adults. The second one was unexpected. So this study, we looked at 100 adults that had food allergy, that had EpiPen prescriptions, and we ultrasounded their legs with firm pressure, kind of simulating giving the EpiPen, to see if the EpiPen would get into the muscle for our patients with food allergy. So the EpiPen needle is about 15 millimeters long, and we identified that 30% of women, the EpiPen would not get into the muscle. Men have less sub-Q fat in the leg. I think we tend to have more in the gut, which may be worse in terms of other problems. But certainly in the leg, women have more subcutaneous tissue. So 30% of women have a risk of it going into the fat instead of the muscle. What we estimated, if the EpiPen needle was 25 millimeters long, 1 inch, and there's a product in Europe with a needle that's 1 inch long, if it was 1 inch long, then we would be okay with 96% of our patients. So what I have recommended, but we have not been able, we don't have this product in Canada yet, is a product with a 1 inch long needle. And so hopefully we'll get that in Canada soon. So this is an image of an ultrasound. So this is the skin up here. This is the femur or the bone here, pretty obvious. And then this is the muscle fascia, the lining of the muscle. So what we want is we want the EpiPen needle to go into the muscle and inject here. And so what happens with 30% of women is that the EpiPen injects here and may not get into the muscle that we want. So very, very simple study. And then just graphically for women, about 30% of women would get the injection into the fat, not into the muscle that we want. So this was actually kind of expected. We expected with the obesity epidemic that was happening in Canada and North America that we would see more of this. The thing that shocked us, we expected this to happen in all age groups, from babies up to adults. The thing that shocked us were the findings of this study. We were not expecting to find that in young kids, the EpiPen would actually hit the bone. This literally shocked us. This was a complete surprise. So again, we ultrasounded 100 kids. Now the EpiPen Jr are officially for kids between 15 and 30 kilos. So we have to use the EpiPen Jr even in kids less than 15 kilos. So what we wanted to do was find out if the EpiPen needle was appropriate for kids less than 15 kilos. And we identified the opposite of what we expected. We identified that 30% of these kids might actually have the EpiPen Jr, the needle length's about 13 millimeters. The EpiPen needle would actually hit the bone and could potentially be harmful. And we repeated this study in another format, and in that study, actually 44% of kids had the risk of hitting the bone. So in the US, actually, based on our research, they actually have a product for kids less than 15 kilos with the needle length of 7 millimeters instead of 12 millimeters, 13 millimeters. So that's something, another product that we'd love to get into Canada for safety issues. So again, in a simple pie graph, 30% of kids less than 15 kilos in our study have a risk of the EpiPen hitting the bone, which is not good. So the way we recommend giving the EpiPen now, this is a fake one. About 4 months ago, there's one called an Allergic, they're the small ones that talk to you, that we have available in Canada right now, at least for a year. So I wanted to show a patient how to use a fake Allergic. So I pulled the Allergic out and I took the safety off and I just wanted to show the patient how to use it. And I put it in and it went, it was a real one. It just lanced my cell phone and went into my leg. And so now I know what an Allergic feels like to inject into my leg. It's not a big deal. This is a fake one, for sure. So So what we recommend, typically what they suggest on the container here is to take the safety off and then just take it and then just swing it into your leg. And that's kind of how we've taught people how to use it. And we used to tell people to hold it for 10 seconds. So we don't recommend that anymore. So what I recommend now is for adults is just take the safety off and put it on the muscle right halfway between the knee and the hip. Just put it there and then press and just hold it for 3 seconds, not for 10. The needle releases very, very quickly. For young kids, what I recommend is to take the safety off. Young kids like less than 15 kilos, take the safety off, and instead of swinging it in, what I recommend is holding the muscle so the muscle doesn't compress. So hold the muscle, squeeze the muscle, and then just hold it on the leg and then press without whacking it, and just hold it for 3 seconds. One of the reasons we recommend holding it for only 3 seconds is because there was a really, really impressive case series, a number of patients, young kids mostly, of reports of injuries from EpiPens in the States. And the injuries are impressive. One kid had like a 10 centimeter long laceration on his leg. And the reason for that is pretty clear. You put the EpiPen in. We used to tell the parents to hold it for 10 seconds. So you hold it for 10 seconds, the kid's flailing around, and the needle's lacerating the kid. So there's cases of lacerations, of EpiPen needles breaking into the body, EpiPen needles being stuck in the bone. We reported one case where one of our patients injected into the bone. I've had at least 3 or 4 cases of the EpiPen hitting the bone in patients. So that's why we recommend just 3 seconds. And as I've mentioned with young kids, just hold the muscle and then press. You don't have to whack it as it says to do on the container. So now we have peanut oral immunotherapy as our focus of discussion. And we have Lauren Cohen to come and talk with us about her experience. Lauren just graduated to basically one peanut a day. And Lauren's going to talk about her experience with peanut immunotherapy. Go ahead, Lauren.
So I had my first allergic reaction just before my 4th birthday. And although I was young, I remember taking a big bite out of a Mr. Big candy bar and immediately thinking, I don't like this. But I had a history of being a picky eater. So my parents just set me down for my nap, my dad ate the rest of the chocolate bar, and they went about their day. And it wasn't until a couple hours later when I finally woke up from my nap, covered in hives, that they realized something might actually be wrong. I distinctly remember sitting on our back porch waiting for my mom to get a call back from our allergist, only to find out that my allergy was too severe to do anything about, except to stay away from peanuts at all costs. So I stopped eating food from other people's houses. I stopped eating at bakeries, at restaurants that we didn't trust, which was anything but McDonald's. And I never went to friends' houses for dinner, or even I never went out for ice cream. Like Dr. Kim mentioned, I never had cake at people's birthday parties. Every time I went to a birthday party, I'd bring a little 2-bite brownie, and I'd put a little frosting on it, and I would just sit in my corner and eat that instead. And so I went on living my life in a peanut-free bubble. And from a young age, I was learning how to carefully read labels, and I was even educating my peers on what it was like living with food allergy. When I later broke out in hives after touching a shopping cart, I became very aware of the fact that anything around me could have come in contact with peanuts at any time, which caused me to start living with perpetual anxiety for my safety. Finally, in 10th grade, after 12 years of living with a peanut allergy, the unthinkable happened. During a book club meeting, I accidentally ate a peanut that I was hiding in a bag of bridge mix. I was too young to know what that was, so I thought, oh, it's stuff covered in chocolate, yum. Being a chocoholic, I was having fun, eating the different ones. Oh, mint, cherry, almond? I accidentally ate that peanut, and I tried to brush off the fact that I'd just eaten the food that I spent 12 years of my life avoiding successfully. And I tried to go about my day, which included taking a photo for the book club, which is still in my yearbook. You can see I've got a rash on my neck as we took the photo. It's quite a memory. And I even went to class. It wasn't until half an hour later that I started to have really bad stomach pains, that I had to face the fact that I was having yet again another allergic reaction, to which I began crying uncontrollably and vomiting on the library floor. The school nurse called my mom, who was working here at St. Joe's, and explained the situation, telling her to meet me at the hospital in St. Thomas. Despite the fact that I somehow was bright red, sheet white, and felt like my skin was on fire, I refused to take my EpiPen. After all, I was a 15-year-old in medical distress and was not a big fan of needles. I came very close to losing consciousness in the hospital and was given an IV in the hallway. Between fits of sobbing, I was trying to crack jokes and making my paramedics laugh, which was, again, quite the memory. All the while, my body was shutting down. And Dr. Kim showed the different systems that can be affected by anaphylaxis. I had most of those most of those were shutting down for me, like my skin, my gastrointestinal, everything was shutting down. 2 months later, I had my allergic reaction in January. 2 months later, in March, I began oral immunotherapy, which was scary and exciting. Now years passed, and every day I eat the same amount of peanut that once killed me. It's pretty fun. This program's not only allowed me to be able to go out for ice cream, finally, after 17 years of life, but it's also allowed me to eat birthday cake, and it's allowed me to feel safe in what were once unsafe environments. I can now eat at new restaurants, go to friends' houses for dinner, and I can even travel safely. Fun fact, I tried to go to Europe before I did oral immunotherapy, and my tour guide hated me. Every time we had a meal, is this safe? Is this safe? Can I eat this? I was never able to do these things before, and I am now. I'm now able to live without the constant fear of being exposed to peanuts, and all of my anxieties surrounding my allergy, and my mom's anxieties, have all been alleviated. She no longer has to worry about my safety in terms of my allergy, which has been the biggest relief after 12 years of fear. When she found out all that I'd be able to do after immunotherapy, she was so happy for me. For a while, she couldn't even look at me without crying tears of joy and relief. I would be sitting there on the couch, and she would look at me, and she'd just start bawling, and I'm like, please stop crying. I don't want you to cry when you look at me. Immunotherapy has given me so many new freedoms, as well as courage to face new situations that I otherwise have never been part of. I'm so thankful to Dr. Kim and the rest of the staff at the Allergy Clinic for this life-changing opportunity, as well as my mom for making it all happen.
Yeah, that's quite a story, and that's Lauren's one example of why we do this. And Lauren's mom, I think Lauren's mom cried, when she had her peanut in the office too. So let's talk about peanut oral immunotherapy. So these are the foods that have been studied reasonably well with peanut oral immunotherapy, or with food oral immunotherapy. Peanut is by far the one that's been studied the most, with lots of research, and we'll talk about a few of those studies. We've also started a number of kids with milk, and we're just about to start our first few kids with egg. These ones actually are probably a little bit more anxiety-provoking for us than peanut. Peanut, just because the research is so good. And as you've heard from Lauren, the safety is a huge thing, obviously, and that's our primary goal. But the quality of life improvements are something that we talk about to some extent. But when you actually see patients go through it and see how anxiety can change to much more of a relaxed life, it's amazing the impact that a relatively simple treatment can have on patients. So about 2 years ago, we'd been doing this for a little while in our clinic here. About 2 years ago, the Free Press and CBC covered this story, and then after the story started, we had quite a number of patients get referred for this treatment. And so we'll talk about kind of what we do and a bit of science behind what the rationale is. So before we get into the treatment, I thought I'd talk briefly about, and I alluded to it a little bit, about how we, I think, will have a huge impact on food allergy by preventing it from happening at all. So, this is typical of what we see in our clinics every day. So 10-month-old female eats peanut butter and has skin symptoms and hives, okay? And it's immediate onset, lasts 20 minutes. The parents tried again, and the symptoms recurred. This is pretty typical of what happens, because the parents often are like, wow, I can't believe that really happened, let's try it again. And so, pretty common, especially with physicians' kids. We tend to be the worst. And then, and we skin tested the child, and she had an 8 millimeter positive test, which is very positive. At 8 millimeters, the risk of reacting is 95%. So this is almost 100% confirmatory of the diagnosis. So the questions that we've had over the years are, what if we had introduced peanut to this kid at 4 months of age instead of waiting? And as you know, not so long ago, we used to recommend waiting until kids were 4 or 5 years of age before we introduced these foods. And then another question is, will she outgrow the peanut allergy once she has it? And then the third question is, of course, treatment, which we'll talk about. So at this point, I'm going to show you a study that changed our management in terms of prevention. In terms of outgrowing it, once a child has peanut allergy, we know based on one large, well-done study that about 15% of kids will outgrow it, but most kids with peanut allergy keep it forever. So let's talk about prevention. So this, I think, will be huge if we can implement this across the country. And it's slowly happening, but I think we need some help from Public Health Canada and the provincial public health groups and the local public health agencies. We know now that if we introduce foods, specifically peanut for sure and egg almost for sure, between age 4 and 6 months of age, that we could prevent about 90% of peanut allergy, 90% of food allergy, if we get it in really early. And this, of course, is a major shift in what we've been recommending, but we truly believe this is true based on a couple of studies, and I'll show you one in a second. This was the product that changed everything. It's Bumba. It's a very, very popular Israeli snack for young babies. It's peanut butter cheesies. They feed this to babies very, very early in life. And at the point where by age 1, almost every Israeli kid has eaten this stuff. And we actually have this available in Canada now. So the Israeli doctors identified this, and they thought, well, maybe we don't have peanut allergy in Israel because we give all of our kids peanut early. So about 10 years ago, there was a study done where they looked at Israeli kids and Jewish kids from England, and they identified that the Israeli kids were about 90% less likely to have peanut allergy than the Jewish kids from England. So then they went ahead and they performed this large randomized controlled trial that was actually published in the biggest medical journal, New England Journal of Medicine. And they took 640 kids that were high risk for becoming allergic to peanut. So they had either already had egg allergy or they had severe eczema. And by the way, I'll point out this as well, is now we believe that eczema may be the source of food allergy. In other words, the kids become allergic because the food gets in through broken down skin. And so now we're really encouraging, even in young babies, to treat eczema so that the skin stays healed up, so that the peanut doesn't get into the skin. So in this study, what they identified is they randomized these kids to either receiving peanut very early in life in high amounts, weekly, or the standard of care, which was avoiding peanut completely. And then at age 5, they went back to see what happened to these kids. And what they identified was, if we introduced peanut into kids early in life, that we might prevent peanut allergy. In this study, they did prevent peanut allergy. Again, almost about a 90% reduction in peanut allergy. So it makes sense that we should be introducing peanut early. And in this study, I think the impact would have been even greater if they started at 4 to 6 months instead of 4 to 11 months of age. So the reason that we started looking at peanut oral immunotherapy was, as Lawrence pointed out, there's a high risk of accidental ingestions. There's a major impairment in terms of quality of life and social function. And then there's studies done suggesting that the quality of life with food allergic kids is similar to the kids with diabetes. So this is a big impact on people, huge. And so we believe that active treatment is required. And this type of treatment is very similar to the old standby allergy shots that we've been giving for 100 years, literally, where we give tiny, gradually increasing doses of allergen so that your body becomes tolerant or immune to it. And this point's important because one peanut has about 250 milligrams of peanut protein, and you'll see through the slides that this is about the target dose that we want to get to with kids. So we want to start really small and slowly get them up to about 250 milligrams of peanut protein, which is about 500 milligrams of peanut flour. So there is a company called Heymann that actually published a large study that I'm going to show you in a second. This is actually a news release from that study showing that in a huge randomized controlled study, a well done medical study, that if we give kids peanut, gradually increasing amounts, that in 80% of kids with confirmed peanut allergy, we can get them up to equivalent of 1 peanut a day. So you'll see in a second what the study looks like. So this was, again, published in the New England Journal of Medicine about a year ago. And they had 500 kids between 4 and 17. These kids had confirmed peanut allergy, and they put half of them on peanut, half of them on placebo, and then they challenged the kids to peanut at the end of the study to see if the peanut actually worked. And this is what they found. I didn't put it here, but 80% of the kids were able to get up to 1 peanut. About 70% of the kids were able to eat 2 peanuts, and 50% of the kids were able to get up to 4 peanuts. About 14% of the kids had systemic allergic reactions through the study. Only one of them had a severe reaction. So this treatment seems to be really effective in terms of getting kids on peanut. So this was the step-up dosing that they did. So they stepped up every 2 weeks. On day 1, they went up very quickly up to 6 milligrams of peanut protein, which is 12 milligrams of peanut flour. And then every 2 weeks, they stepped up until they got up to 300 milligrams of peanut protein. And then they kept the kids on peanut for another 6 months to see what happened. So the whole study lasted about a year. And at the end of the study, they actually challenged the kids to 2 peanuts and then 4 peanuts to see if they were able to tolerate it. So really well done study. And again, graphically, this is what they found. So in kids that were on placebo, so they were receiving fake peanut, very few kids were able to tolerate 1 peanut at the end of the study. 80% of kids that were on 1 peanut. For 2 peanuts, again, about 70% of kids were able to eat 2 peanuts, and about 50% of the kids were able to eat 4 peanuts. That's 1 teaspoon of peanut butter. It's a pretty big dose of peanut. So what we offer to kids now is we want to get every kid up to 1 peanut, and then if they want, over time, we can gradually increase them up to 1 teaspoon of peanut butter or 4 peanuts a day, if they want to really get a small serving amount. This is the data that actually they found in adults. In adults, the study wasn't quite significant. It wasn't quite as effective in young kids. But you can see even in the adults, there was some improvement in patients. And we have 2 adults that are undergoing the peanut oral immunotherapy now, and so far so good with them. One of them actually was driving to the States, to New York, to get this Chinese herbal remedy that actually looked like it was effective for peanut allergy in good studies. But they actually drove weekly or monthly to the States for like a decade to get medical therapy. So now they find it quite nice that they can drive to London and get it without any real significant cost. So these were the kids that reacted. Only 1 kid had a severe reaction in the study. And then again, about 14% of kids total had reactions through the study period. So that's the biggest study that was published. Just about a month ago, we have a Canadian study. We had 2 Canadian studies published at the same time. One that was very pro-peanut immunotherapy and the other one that was anti-peanut immunotherapy. And I think we'll look at both of these studies just to give you an idea of what's out there in terms of medical research. So the first study was the pro study in terms of they were keen on immunotherapy. So what they did in 4 sites across Canada, in Vancouver, Winnipeg, Halifax, and Edmonton, they had about 300 kids. Now these kids were younger, they were preschoolers, okay? And this was not a randomized study. All of these kids got peanut immunotherapy, kind of like what we do here. And what they identified was that they were able to get 90% of their kids up to 1 peanut over 6 months. They had about 10% or less than 10% of kids react. Again, only 1 child in the whole study had a severe reaction. They had a few kids with milder reactions, and 4% of kids required epinephrine through the study. So I was a bit nervous to start young kids on this treatment when we started, but now with data like this, we're actually even more keen to start young kids, and I would say that the vast majority of kids that we're starting now are actually less than 5. And these kids are much less likely to have reactions, so it's been really good. And potentially with these kids, there may be potential for long-term cure, where they can actually eat peanut at serving amounts. So this was a protocol. It's a busy slide. This was the protocol they used. And in about 70% of kids, they did not do an oral food challenge at the start of the study, which was similar to what we do here. So typically what we do here is we will identify kids and then estimate or predict whether they're really peanut allergic or not, and then we'll offer them oral immunotherapy if they want it. So again, in the study, they had about 11 kids require epinephrine through the study out of 270 kids. It's not bad, pretty safe. And then another important point is when you looked at safety and risk of requiring epinephrine or dropping out of the study, the kids that had higher blood levels of peanut were at higher risk of having reactions. But again, most of the kids, even with really, really high blood levels with peanut, made it through. So that's a positive study that was really well received and published in one of the lead allergy journals. This study actually that was done by my colleagues at McMaster was negative. They actually thought that maybe we should not be doing peanut oral immunotherapy. And it was well publicized. It was published in an English journal, The Lancet, which as you guys may appreciate, the English like to stir things up a bit. So they took this paper and got things going a little bit. And so this was not a real study, so they did not do the research themselves. What they did was something called the Metaanalysis, where they looked at 12 studies that had been published to see what they identified. And what they wanted to do was show that kids that were on peanut compared to placebo were more likely to have reactions. And the obvious thing about this study is, of course, the kids that are on peanut are going to have more reactions than on placebo during the study time. And that was the main criticism that we have of this paper. And those of us that do immunotherapy are writing into the journal to point this out. So what they identified is that peanut oral immunotherapy is effective. So if you're on peanut compared to placebo, you're 12 times more likely to be able to eat peanut at the end of the study. So this is extremely effective. But they identified that if you're getting peanut as opposed to placebo, you're about 3 times more likely to have reactions, which again was obvious when we expected this. So this slide is what we typically see in a meta-analysis. If you're on one side of this line, then they identified that this actually goes against using immunotherapy. And this slide shows the same. So I just wanted to point out a couple of main points about this study. And the first thing, as I pointed out, is that we expect this anyways. And the other thing that they did not focus on was that they should have done it showing that the stuff actually works well. This variable here, showing that peanut immunotherapy is very, very effective, should have been the take-home message, not the side effect risk. And so if you think about something like antibiotics, if we did not prescribe antibiotics because people got diarrhea from getting antibiotics, and if then we would we wouldn't use it. But you'd be forgetting about all the people that didn't die from the infection that they were being treated for. Or if we did not give aspirin for heart disease because people on aspirin had an increased risk of bleeding. Of course we expect some increase in side effects with some of our medical treatment, most of our medical treatment. So again, I think this study has a major flaw of looking at the wrong variable. They should have looked at the primary variable of showing that it's effective. So in London, we're offering peanut immunotherapy for any age child. You'll see in a second, we've started a 9-month-old now. And what they need is a good history for a peanut reaction, a positive skin test and a positive blood test for peanut. And if it's kind of questionable, then we do a food challenge to confirm that they're allergic before we go ahead with treatment. And of course, the patients have to sign an informed consent. So this is the protocol that we use. We take peanut flour and we mix it either with lactose or with oat flour. And we prepare them into tiny little capsules, like they're pill, the capsules like medical capsules. And what we do is we have the patients just open the capsule and mix it into some applesauce or some yogurt or pudding, and they eat it. And the dosing schedule is 0.5 milligrams of peanut protein up to 250 milligrams. We thought that it might be better going slower, so we go up every month instead of every 2 weeks. At the end, the patients graduate either to 1 M&M peanut, if they're not allergic to milk and they're not allergic to, there may be almond in M&Ms, so if they're allergic to those, then we give them peanut butter. And for most patients that are on M&M peanut, we also later make sure they can take peanut butter a few months later. So now they're able to have straight peanut or processed peanut in terms of peanut butter. And then if the child and or parents are keen, then we will gradually increase the dose up to 4 peanuts or 1 teaspoon of peanut butter if they want. So that's kind of the protocol that we use. I give all of our patients my cell number, and so they can text me anytime with questions or call if there's anything urgent. And so this process has worked out pretty well. So there's about 12 allergists in Canada or in Ontario doing this. In London, there's 4 of us doing it. In Ontario, we're the only academic site that's offering the oral immunotherapy. And St. Joe's, of course, is the hospital that we're performing it in. And it's the only academic center in Ontario doing it. So we have been quite busy with it, but it's been enjoyable and fun. As you can see, the outcomes kind of make it really, really worthwhile for us. So these are some of the numbers, and I know the numbers because we're just looking at our data now, but so there's 200 patients that we've started. The age is between 9 months and 23 years of age. We've completed about 100 kids now, really. So half of them are finished up to 1 peanut. We don't know what the dropout rate is yet. We haven't gone through all of our numbers yet. We have had now 4 patients with systemic reactions, 1 today. So it doesn't happen very often, but it does, it can. All of the reactions have happened with teenagers. The young kids seem to tolerate it more. We've had 3 females now and 1 male with reactions. Often exercise plays a role, or sometimes when kid has a cold or allergy symptoms are flaring up, their symptoms flare. This is an interesting thing that we've started doing. A lot of kids, especially the teenagers, really don't like the taste of peanut because they've developed this defense thing. So we often have kids actually just swallow the capsules. They take it with some other food, and that seems to make it much more tolerated. So that's made a difference as well. So this is what we do, and again, it's been a lot of fun doing this. We're just in the middle now of preparing a Canadian food oral immunotherapy guidelines. It's a massive project. Hopefully we'll have it published by next year, but I think it's going to be a great paper. And another thing that we've really trying to get out is just the idea of getting education and research funding for food allergy. So ourselves, the Canadian Society of Allergy and Food Allergy Canada have partnered to start a Food Allergy National Action Plan. And so we were just in Ottawa about 3 or 4 weeks ago talking to some MPs and bureaucrats about trying to get this on the political and the political platforms for the election coming up in the fall. So hopefully we'll be able to raise the awareness of food allergy. And I think so far so good. So to close, peanut allergy and food allergy generally has the potential now for treatment. We're very optimistic that all food allergy will be immunotherapy for all food allergy will be available. We're starting even tree nuts and possibly sesame. There's some studies coming. So I think for many foods we'll have this. It is effective, as we've discussed and you've seen. I think our guidelines will be really good for guiding us as physicians in Canada in terms of how to do this properly, safely. One thing that has to be mentioned is that this has to be done very cautiously because there is risk. And so we really do want to follow safe protocols and have the infrastructure set up properly for this process. And so I would like to thank the foundation and the help that they've provided for preparing this and getting medical education out about all of the topics that there have been discussions on. Our patients have been wonderful. It's amazing how keen the patients are. Quite nervous at the start and a little bit nervous at the end, but very, very good, great group of patients that we have. 3 of our colleagues have retired over the last year and a half. Doctors Butchie, Payton, and Mazza, all of them excellent colleagues and allergists. And so these guys retiring have made it very busy for us. So we're actively trying to recruit now. our administrative team at St. Joe's, our pharmacy, I forgot to mention, our pharmacy's done a wonderful job of preparing the capsules. And so they've been a little bit flooded with work, but they've done an amazing job with preparing all of the doses up to 500 milligrams. Our nursing staff have been wonderful and have accommodated the busyness of the clinic for us. And of course, our colleagues, so Dr. Moot, Dr. Kaprosky, Dr. Jamie, and Dr. Roberts are all allergists that work with us here at St. Joe's, and they've all done a wonderful job of having this project work. And then the last slide is this. Shauna has helped us set up our division research fund here at St. Joe's, and our goal is to try to get kind of like a base of research funding to start food allergy. We have a couple of food allergy projects already going in terms of small research studies, but as you can see with the data that we'll have from our patients that we've done already, as well as a number of other areas in food allergy, we're hoping to start publishing in this area, publishing more in this area here at St. Joe's. So Shauna, I'm sure, would be happy to be contacted if you guys would be willing to support research here with food allergy. So thank you very much. And,
All right. Hello, everyone. My name is Will Heymann, and I am on the foundation board, and it's my great pleasure to be here with you this evening, listening to this presentation and going through the emotional roller coaster of hearing Lauren's presentation and sitting beside Judy as a grateful patient and mother. And I can tell you the tears were real just even in just watching with the pride and the hope that we have there. So it was amazing, and I think I speak on behalf of everyone here in saying thank you so much to Dr. Kim for sharing your story tonight and for also being such an amazing asset in our community. So thank you. So we have this small token of appreciation. I cannot speak to the trace amounts of peanuts that may or may not be in here. However, So I know that you said that you were recruiting for allergists, and I also saw that we might have a future one in the room. So, but one of the numbers that really jumped out to me in listening to that is that there are so many people that are actually affected by food allergies, 2.6, and many people who know them right here in this room. So, and only having 12. I say only, but to have 4 allergists who are doing this type of work in the community just makes me feel very grateful to be here in this community. A big part of one of the reasons why I got onto the board of directors at St. Joe's Healthcare Foundation is being able to work with an organization that's supporting this type of work and being able to work with the clinicians who are doing research and their staff here that are helping to advance the medical field right here in London. As you might know, we're halfway through these DocTalks. Did you like this evening? Was this good? So this is a regular thing that we have going on right here, and so we're halfway through this. So if you're interested in finding out more about future DocTalks, you can go on to the St. Joe's Healthcare Foundation website. You'll see the schedule of upcoming events. You can also sign up to get those notifications to be invited to them. I can tell you that the next one that we have that's on September 17th with Dr. Tim Doherty is going to be explaining and exploring how nerve and muscular functions are impacted by aging, and he'll also be sharing the best ways to maintain healthy muscle mass and mobility as we get older, because we get older. I don't know why we choose to do that, but we do. So it's definitely going to be a popular topic, I can assure you. So if you are interested, be sure to register early, because as you can see from this room, I mean, it's a pretty popular thing. So get on there, I would say. And lastly, I just want to say very much thank you to our corporate sponsor, CIBC, for making tonight's presentation possible, as well as to all of our donors who are here in the community and maybe right here in this room. If you are one, thank you so much. It's because of your support that we're able to put on and have this research going on. And if you're interested, please do reach out to Shauna, because I know I was talking to Dr. Kim before, some really exciting opportunities that we might be able to get in on in terms of doing that research. So it's been a pleasure being here tonight. Thank you so much for coming, and I hope that you enjoy the rest of your evening.